So, welcome to Project Echo. Today is Wednesday, February the 4th. I am Lindsay Zimmerman. I'm the Viral Hepatitis Prevention Director for the Tennessee Department of Health. I do want to make a note that although our Project Echo series is ran out of the Department of Health, we do encourage community participation. So, if you do have any external partners or agencies that are interested in learning about hepatitis C treatment, or expanding what they already offer, please feel free to pass along our information, or you can also email us at echo.tn@tn.gov as we aim to expand hepatitis C treatment across the state to not only internal partners but also external. So for today's session, we are going to have Dr. Clark Allen, our subject matter expert, discuss navigating insurance with hepatitis C treatment. So we hope to have several questions answered during today's session. We will have two case presentations and then an opportunity for Q&A at the end. If you are interested and you are new here, we do offer continuing education credits for each session. It is a free 1 hour credit. Registration to obtain these credits is separate from participation in Project Echo. You do have to set up a profile through the Southeast AIDS Education and Training Center. You can do so by using the QR code on your screen. And registration will have to be completed for each session. Participation does have to be completed for the full session, and then there will be a post-session evaluation survey to be completed at the end. Kimber has included the link in the chat for the credit, so that way it makes it easier for you. I see some familiar faces and names, but please feel free to drop your name and your organization and your role in the chat and include your information as far as if this is your first Echo session. And I'm just going to pose a question for you all. Those of you all that attended sessions last year, towards the end of the 2025 year, I did include some kind of icebreakers during these moments. And so we would discuss different unrelated topics in the chat. I haven't done that this year, but I wanted to ask if that's something that you all are is of interest to you, or if you would be if you want to discuss those for future sessions, or if you just prefer to just kind of keep it pretty straightforward. All right, I got one vote for icebreakers, so let's plan on it for the next session, okay? And we do that just to kind of engage in participation and conversation. We want this to be an all teach, all learn experience. So please know there's no silly questions. We do very straightforward information. We discuss very complex information. We welcome all types of information. So don't hesitate to come off mute. Don't hesitate to drop your questions in the chat. And yeah, we're all here to learn. So welcome you all. We'll go ahead and move forward. If you have any technical issues during today's session, please do not hesitate to reach out to Kimber Miller. Her information is in the chat. But without taking any more time, Dr. Allen, I'm going to go ahead and turn it over to you.
All right, thanks for the introduction, Lindsay. So today, we're going to focus more on after the diagnosis, after the lab work, more of the getting the approval with insurance type aspect, and then pitfalls, challenges, things that you might come across with the prioritizations, copays, things like that. So that'll be more of the focus for today's session. And then if something that I cover, I'm going to try to make sure that I keep this to layman's terms and not go into super pharmacy specific things to make sure I explain everything that I'm talking about. That way, everybody's on the same page of what we're going through. It's more of not necessarily explain everything about it, but to expose you to the process of what happens after you send that prescription to the pharmacy, because I want you to be able to troubleshoot things if your patient calls you needing help. I want you to be able to help them navigate, be able to talk to the pharmacy, things like that. We can go to the next slide. No conflicts of interest to disclose with this presentation. Next slide. Got a couple objectives here. I want to make sure we address clinical information needed for insurance requirements, looking at formulary options, different insurance plans, and also potential pitfalls associated with copays with these medications, because inevitably they are expensive and we need to know how to navigate those waters as well, and things that can come up or things that have been arising throughout the years. Next slide. Several abbreviations, lots of them are very common, but I want to make sure I'm always putting my abbreviations out there. Drug-drug interaction is the main one that may be not known completely throughout the audience. Other ones are been explained before, but I always like to list them. Next slide. So this is going to be the pathway of the conversation today. Is we're going to walk through these steps. This is how I plan for each patient through that comes through the hepatitis C clinic. I'm going to call it the medication use process. I'm kind of stealing that term. It's not that this is not going to be a true medication use process, but it's going to be for my hepatitis C process. So we're going to collect clinical information at the clinic visit. We're going to establish what their insurance status is. We're going to use that information to do a prioritization. Once the prioritization is approved, we'll send a prescription to the pharmacy, work on any copay assistance if we need to sign up for copay card or third-party foundation as needed. And then at that point, we'll get the patient on the medicine, counsel them as needed, and then have them come up for follow-up with either a week 4, week end of treatment, or SVR 12, sustained viral response 12 weeks after treatment, i.e. cure determination. Next slide. So we'll start out with clinical assessment. Dorinda went through most of this process a couple weeks ago, but we'll review it just briefly. Next slide. So these are things you'll want to do at the beginning of your initial visit. Now we're going to assume that you already have a hepatitis C antibody positive test on the patient, and these are going to be the other things that we need to collect. Or if you've already have most of them collected, great. These are the things that I collect on every single patient before I start a hepatitis C evaluation. So I'll get a CBC, CMP, INR, because we want to assess that for liver function. We also need that to assess for Child-Pugh score. We'll need a hepatitis B panel. We've talked about that in the past, why we need that. Genotype, viral load, and we need to stage the liver in some form or fashion. Most insurance companies acknowledge a FibroSure or a FibroScan or liver biopsy. Not many people are going to be doing liver biopsies, but less so will be accepting of the FIB4, the APRI score. You can sometimes utilize it if it's a very, very low score, showing that there's absolutely no fibrosis on the patient's liver. So that's one argument that you can use if you already have some of the basic lab work values that you can use to calculate that. If you're in the gray area or higher values, then yeah, you definitely want to use one of the other staging tools of the hepatitis C or the FibroSure or the FibroScan. Pregnancy test for anybody in that stage of life, and then any type of previous treatment history is also great to collect, and any drug interactions. I want to have all these things of information to collect before we decide on a treatment. But we also got to, once we've established this piece, then we need to establish what their insurance status is, because now that we have our side of it, now we need to see what the insurance says as well. So now we can go to next slide. It's kind of just be an introductory slide, because this will be the rest of the time that we spend today is navigating insurance. So several different plans. There's either going to be commercial plans, either through employers or the marketplace. They can also be on Tennessee Medicaid or Medicare, depending on their age or their conditions. They can be on any one of these. If they're self-pay, I would direct you to a different presentation that I had. I believe it was March of 2025. If you want to go through the patient assistance route, you can review that session for more information on the patient assistance side of it if they do not have insurance. Next slide. So once we've established what type of insurance they have, some insurances will have their formularies readily available online. Not all of them, so it kind of is a hit or miss thing. Usually, I'll try to use the internet to search through and find out if the formulary is available. That way, I can know what is preferred and what's not without just going through the prioritization process blindly. I like to know. So I've highlighted the ones in green are the most common ones that I see. So this is not universal, but this is what I see on most insurance plans now. They're either preferring brand Maverick, Capital or the authorized generic of Epclusa, which is Sofosbuvir Patisiran. Those are the main two I see that are preferred now. And then I highlighted the ones in yellow that are available, but you may have to do some extra documents as to why you want to utilize those agents. So brand Eclusa, I feel like is being fallen out and being replaced by the authorized generic just because of most insurance plans are changing to that. And then, of course, brand Harvoni, Ledipasir, and the generic authorized generic of Harvoni are falling out of favor just because they want to. Most insurances have adopted pan-genotypic agents, which is both Sofosbuvir, Patisiran, and Capital. And then I put Orange, the last guy, because he is considered for salvage treatment. So we'll hold him in his own special place, which is Cephalosporin Velpatasvir Voxaprevir, brand name Vosevi. Next slide. All right, so this is where I feel like a lot of people may have questions. So there's different ways to do prioritizations. Pretty much, I've yet to see an insurance plan that does not require prioritization for hepatitis C medication. So go ahead and just expect that that's going to be the case. I don't even attempt to send a prescription before I get the prioritization approved, just because I know it's going to happen. So there's different ways that you can submit prioritizations depending on the insurance plan. It can go through a medication access company. The most common one that people will use is Cover My Meds. There's also other ones out there. An insurance plan may have its own specific portal, and it may direct you from Cover My Meds to go there, or it may be somewhere in some documentation that you have to use a specific portal, and they usually will give you a link to where to go. Some insurances prefer phone, or some prefer fax. So there's everyone's different. I'll use Tennessee Medicaid as an example. They still prefer, even if you go through Cover My Meds through the online portal, they still prefer you to print off the form and fax it in for hepatitis C medication specifically. So that's one example of they still prefer a paper form, fill it out, and fax it in with all of your lab work and documents. Which brings me to my next point. We want to make sure that when we submit a prioritization, that we're supplying our chart note, establishing what the patient's here for, what that you've established risk factors, where they got it from, what's their treatment history, and what you're kind of thinking about what you want to start as far as treatment. You want to supply their lab work as well, proving they all the clinical information that we just discussed, making sure all that's listed. That way, one, you're evaluating it for yourself to make sure you're picking the right medication, and two, they want to see that information as well because they want to make sure that the patient is fully indicated to receive hepatitis C treatment. Just because it's a high price tag, they want to make sure that they're not giving out hepatitis C medications to anybody. They want to make sure it's warranted. And then, of course, if there's a time where we want to go off the formulary of the insurance plan, that's when we want to provide extra clinical documentation, either through mainly when I use extra clinical documentation, it's going to be for drug interactions that I want to avoid the formulary option. And I will usually either print off the information from Lexicomp or the Liverpool Interaction Checker. I'll have that information. I'll circle the interaction, explain why it's a contraindication, why that's not safe and not helpful, and it's not going to be effective for treating the patient for hepatitis C with the preferred agent, and that's when we need to switch and pivot to an alternative medication, and that's when I will state my case there. So usually they're going to give you a comment box of some sort at the bottom of the either on Cover My Meds, they'll give you a comment box, or they might give it to you in a supplemental fax. So be expecting it can come a couple of different ways of how they can give you to elaborate on why you want to use what you want to use, why you want to go off formulary. There's a couple different ways of how you can do that. But that's usually the time when I need extra documentation for non-formulary requests. And then if worse comes to worse, if you're going off formulary and they still deny it and you need to go through an appeal process, you're basically you're just going to need to be more elaborate and write a full letter of medical necessity, kind of explaining your patient case in detail as to why you don't want to use the formulary option and why the non-formulary option is the best option for the patient. And then, of course, have your same documentation, if not add some more in to kind of state your case further, because you want to do as much as you can as far as giving them as much detail as possible as to why you stand on what you stand on. Any questions about this slide? Because I know this is a lot of what providers have questions about. So I want to pause here for a second if anybody has any questions or comments before I move on. I'll give it a couple more seconds, see if anybody wants to put anything in the chat. I'll keep trying to watch the chat, see if anybody's still typing along the way, but we can go ahead and go to the next slide, and I'll stop if I see something pop up in the chat. So now that we're going to assume we've got a prescription, or we got a prescription, or got a medication approved, now it's time to send the prescription. To my knowledge, I have to send it to a specialty pharmacy, whether it go to, I won't be able to send it to Walgreens or CVS. It'll likely need to go to the specialty pharmacy of those respective pharmacies. So usually I have to figure out which one it needs to go to. We have the luxury of having a specialty pharmacy here that I work in. So I'm kind of a one-stop shop to make it a streamlined process. But for providers that don't have a pharmacy attached to them, I prefer finding a pharmacy that's either local or that you can get in direct contact with, that can fill hepatitis C medications, that you can develop a good relationship with. That way, when things come about or issues come about, you can talk to them quickly versus having to go through a bunch of phone trees and things. So that would be my one recommendation, is finding one pharmacy and kind of just using them and building a relationship with them. Now, of course, there's going to be insurance companies that prefer a specific contract pharmacy. That will happen as well. But you won't know that until it's kind of a trial and error thing, that you'll learn that certain insurance plans will require certain pharmacies. And that might be a trial and error thing too, where you send it to your preferred pharmacy and then they call you and say, hey, it has to be filled here. And then you can either have them transfer it or send a new prescription. Either way is fine, because the first pharmacy won't be able to fill it. I also want to make sure that once you get it approved, keep an eye on your prior authorization approved window. It's only going to be approved for either 8 weeks total or 12 weeks. So that means you've got to get 3 fills in a 12-week period, or the 2 fills in an 8-week period. That means you have 4 weeks to get them started on medicine, to make sure you have enough time to get all 3 fills in. If there's a delay, you just have to know that you're going to have to renew the PA on the back end to extend the PA if there's delays in getting the patient started. So having a good relationship with the patient, good relationship with the pharmacy, makes this a streamlined process. And then that's everything I've covered on here. All right, there's lots of specialty pharmacies: CVS Specialty, Walgreens, Walmart, Costco, Optum RX, Secreto, all kinds of them out there. But I usually would recommend just finding one and building a good relationship. And then, of course, there will be one-offs where you have to use other pharmacies for specific patients. And then if that comes about, it comes about, and you just roll with punches. Next slide. So now that we've sent a prescription to the specialty pharmacy, there's likely going to be a copay, sometimes not. We never really know for sure, because we don't know. There's deductibles, there's max out of pocket, there's all kinds of things that come into play on the billing side. So I'll go through these one by one. Tennessee Medicaid, I say you can't use copay card with Medicaid insurance plans. And I say that it's really not necessary. I'll say the word really, because it's really not necessary, because there is a small copay. $1.50 or $3. I usually will think that patients can afford that. If they can't, there is a time where you can talk to the pharmacy about hardship, about maybe waiving that copay and kind of setting up something to take care of that on the back end. So that's for Medicaid only. I made sure I looked at the law and made sure that is a thing before I say that out loud to anyone. So that is an option if patients can't afford that copay and they're a Medicaid patient. Now, Medicare is different. Still no copay cards available, and sometimes they will have large copays depending on what their deductible is. This is when we can use third-party foundations for assistance. Now, there's several of them out there, but the last time I checked, there's only a couple that have open funding. There's Healthwell. It's closed right now from last I checked. There's the PAN Foundation. There's the Patient Advocate Foundation. That one actually is open right now. I saw that they have allotments of $6,000 that they can put toward helping out with patients with Medicare. There's also My Good Days, and there's also the Assistance Fund. It has a wait list on the Assistance Fund right now. So there's several of them out there, and you may have to watch on when you have access to them, as to if you've got a person that has a high copay, with a Medicare plan, but you're having trouble getting assistance. There's also a new thing that came out in 2025 about a payment program for Medicare patients. I don't want to elaborate on that, but that is an option for patients to kind of spread out their copays if they have a large one on the front end of their first prescription. And then now we'll move to commercial. And if you're a type A person, you're wondering why I put the C in front of the M's in alphabetical order. I did that for a reason because we've got more to talk about. So the commercial plans, we are allowed to use copay cards. They have them available for the brand and the authorized generic. So the authorized generics of Harvoni Epclusa, they both have copay cards. I'm going to see if I can. It's kind of hard to find, so I'm going to type the link into the chat because there's a couple different ways to get to it, but only one way is the correct way. So you can sign up, just have the patient sign up and then provide that to the pharmacy. And the difference between the two, the brand name copay cards, they go up to $6,000, but they can also exceed that and go up to 18,000 total. But you have to call to get that, and so that's the benefit of the brand name agents of still having higher copays. That's just for brand Epclusa. Mavericks is separate, but it still has a higher threshold than the authorized generic of Epclusa. That one's a hard stop at only $6,000. So when I'm if I have an option, I'm going to still prefer the brand just because I know I have more copay assistance available with the brand name agent versus the generic. But if the agent or if the insurance plan prefers authorized generic, then that's what I'm going to go with, and I'll make sure I can still make sure the copay is addressed and make sure we're going to meet all of their deductibles and max out of pockets with the funds provided before we start. And then I've almost got this typed out. Okay. I want you to save that because it's a little hard to get to the authorized generic copay card site. So have that available. So now we can go to the next page where we run into issues with insurance plans. So I've got a lovely article here that I want you guys to write the name down. It's pretty easy to find. It's a full text article. You can read the full thing that's published out there, and it kind of goes through what insurance companies have started to employ or employ out there for something called copay accumulators, copay maximizers, and alternate funding programs. Dr. Chastain may recognize some of the people on this article as some of them work at Vanderbilt, but it's a great article. It gives explanations about what's happening with insurance plans and how they're adjusting how they utilize copays or their copay card access and what they do with the funds. And so we'll go to the next slide to kind of go a little more in detail about the first 2 points. So copay accumulators, they're a little different, but ultimately they're a little the same. So copay accumulators, I'm not going to try to read this because I know you can read yourself, but what they're doing is they're using the copay card and using those funds to pay for the patient's copay. But the problem is the copay accumulator plans don't actually use the copay card funds to count toward the patient's deductible and the max out of pocket. So the problem is once they have exhausted the funds on the copay card, the patient is still left with paying their deductible and their max out of pocket is still present. It didn't affect that like it did in the past. So this is a way that, based on what I've learned, that insurance is making sure they want to utilize the copay card, but also utilize the patient paying for their share as well. So this can be problematic with long-term medications, and it can also be complex with the short-term, making sure that we get all the fills in before the funds run out. So this is something that we've run into a couple times. The copay card companies are aware of this, and they want to help you and make sure that you don't fall into a point where you get the first 2 fills to the patient and all of a sudden the funds run out and they're stuck with their deductible and they can't get their third fill. So copay card companies are going to work with you and they're aware of this. There are ways to work around this that I'm not going to talk about online. We can talk about it offline, but there are ways that they go about using this to their advantage and still help the patient, making sure they get their copays taken care of. And then the copay maximizer, a little different. I'm not sure. I haven't seen it play out totally yet with hepatitis C patients, but I see it play out in long-term patients that are going to be on hepatitis or specialty medications for the full year. What they're looking at is the insurance plan is going to look at the max amount that the copay card has in place. And so we're going to use a number of the deductible of the patient and the max out of pocket is $5,000. But the copay card itself, we're going to say is a total of $10,000. So what the insurance company is going to use the copay maximizer and spread out the funds through all the fields. So for us, it's only going to be three or two, but for patients that are going to be on year-long medication indefinitely, they would spread it out over the course of 12 months. And so there's a potential that the copay maximizer plans would actually get more money than the actual deductible from the copay card company, and that the patient hasn't paid anything yet. So they're actually getting more money than if the patient just paid the deductible outright versus this. So we've seen copay card companies not want to work with copay maximizer plans at all. And so we're running into that being a problem. So we haven't found a good solution yet because some of the companies don't want to play ball at all because they see what's happening and they don't want to they don't want to help because they know their funds are not being used appropriately in those cases. So we're still the jury's still out on what is the best course of action from my perspective. If somebody's got a good option here or has experienced this and wants to come off mute, I'm all ears on how we navigate this. This is something new that I'm experiencing. And so we're kind of, but it's something, an idea that I want to put out there to make sure you're aware that these things exist in the wild. The third option on the article is alternate funding. And basically, that just means that the insurance plan doesn't cover specialty medications at all, and the patient would be required to pay 100% of the drug. That would mean they would go to patient assistance. And so I'll refer back to the article or the presentation from 3/5 of 2025 to go through patient assistance. So that's kind of a separate thing. It doesn't benefit the plan because it just puts all the burden on the patient is essentially what's happening. Questions about that? So that, yeah, that's a lot. If you haven't heard those terms before, go to that article, read the article, because me giving you an overview of it doesn't fully explain it. There's also videos out there online that you can watch that I watched as well that are very helpful when explaining it. But I did my best to kind of do it in a concise way to kind of at least expose you to these ideas if you haven't seen these or heard of these, because ultimately, if patients have commercial plans, you will see these if you haven't seen them already. And we just want to make sure we're taking care of our patients, making sure we're able to navigate around these things to still get the patients treated with a full course of the Hep C medicine. All right, next slide. If I don't see anything in the comments. So now the fun part is once we have made it through all those things, and most of the times those things are not going to be an issue, but those pitfalls are out there. But once the patient gets the medication, that's when the a great time for the patient to get started on the medicine. If the pharmacy is likely to counsel them, but you can counsel them as well if you want to. Knowing their start date is important. Also remembering their PA window because they likely didn't start immediately. It takes the pharmacy a couple of days to get it dispensed, get the copay resolved, and all those things. So knowing when they start and then making sure that they can get all of their medication refills in the PA window, or if you know it's going to be late, making sure that you circle back to do another PA to extend the PA. Sometimes you have to extend it and call. Sometimes you can just call and they will just proactively extend it for you, but you just need to make sure you're staying on top of that for the patients. And then potential for insurance changes that usually happens at the beginning of the year. It's more rare in the middle of the year, but you can always mention that to a patient if they're planning on changing insurances in the middle of hepatitis C treatment, because we don't want to have any gaps in therapy as much as possible while we're on this medicine. So addressing that on the front end is helpful. And then, of course, once you know they started, you can have them follow up at week 4 in a treatment or just all the way at SVR 12 for cure determination. Either one of those options is fine. There's no gold standard for any one of those, but we do want to have them come back at the very end for cure is the main one. All right, now we'll go to the next slide. So this is the exception to the rule. We're almost at the end of SVR 12, but we're going to hit a snag. So this is in the rare case that insurance does change in the middle of the course. It basically means the entire process starts over. The new insurance plan has no idea that they're on Hep C medicine. They have no idea about the prioritization. They don't know anything about that. So we're gonna have to work quickly. But you've already got all the information. You just got to get the new card information and do a prioritization. Find out, ask the patient how many pills we got left because we need to know how many days of medicine we have left on hand to know how. I mean, we're going to work quickly, but we just need to know where we're at in the current feel of the medication. Prioritization, sending it to a pharmacy, doing the copay assistance again, getting it back to the patient. So lots of steps need to happen in a quick amount of time if this were the case. So time is of the essence, making sure that you're aware that we want to avoid gaps in therapy at all possible. Is there likely going to be a gap? Potentially, but we know that the medications are still very effective, and we have to take that into account. Thinking about our incomplete adherence or things like that, we will use those rules to make judgment calls depending on how many doses they missed or less. That's great. We'll take that into account on a case by case basis on what we think is appropriate to either stop or continue in that scenario. So every scenario is going to be different. So we'll just you just have to go with it with each time. All right, next slide. So we're going to give a patient case real quick. I know we're running low on time. I want to make sure we have time for the cases. So had a patient that met all these criteria that I just discussed, which is why it was very fitting to give a presentation within 2 months after this happened. So 47-year-old female started on medication, brand exclusive for 12 weeks. At the end of or at the beginning of December, she told me that she was going to change insurance plans at the beginning of the year. It's like, okay, it's great. Thanks for telling me. That way we can plan accordingly. So I made sure when we started, I made sure we could fill the second fill before the new year. That way we could have a full bottle, and it gave me plenty of time to work with the new insurance plan, get it approved, all those type of steps. This is a perfect scenario. This is not going to be every scenario, but it's great for a patient case. So got the new card information on the second, did an insurance preferred authorized generic. So had to switch from brand exclusive to the authorized generic. There's not currently research articles specifically examining switching between the two, but however, multiple studies support therapeutic equivalence between the two agents. So we're comfortable and confident that even though she had to switch for the third bottle to authorized generic of Epclusa, we're still confident it's the equal product. Therefore, it's an equal medication. So it's not really switching. It's just, yeah, it is switching, but it's not really switching. So once I sent to our pharmacy, I learned that it had to go to another pharmacy. It was contracted to a specific pharmacy. So then I had to send a prescription there, signed her up for the new copay card, and sent that information over as well. And calling helps to kind of push that process along because they don't know that this person is needing medication immediately. So I had to call a couple times to kind of keep them rolling to get it to the patient before she ran out. So it's not going to be a perfect world like this, but just knowing that the urgency of kind of pushing this along is the utmost important for the patient to succeed and still get cured. All right, next slide. So now circling back to where we started, the main thing is going through, if you want to take a screenshot of this or save the slides, this is how I work through each patient. And these are kind of the steps that I work through. So just knowing and understanding how insurance payer rules work, how the prioritizations work, how the pharmacy system works, how the copays work, knowing all those things will lead to better outcomes to the patient faster. So just being able to expect these things. Hepatitis C treatment is simple from a surface level, but there can be things that I presented today that can be pitfalls and things to be aware of along the way that we want to make sure you're aware of and how to overcome those challenges. And with that, I'll open it up for questions.
Also, I do want to add that after today's session,